So welcome everyone. This is, I guess technically it says session 2, but oops, I'm sorry. Actually, it's not session 2. It's just that my PowerPoint is let me get back to my PowerPoint slides here. I'm going to stop sharing for just a minute, and it was on the last slide, and so instead of the first slide. Okay, and I will share my screen again, and we will get started. And can everyone see the screen? Is it coming up for you, those that are online?
Yes.
Yes, I could see the screen. I wonder if the other folks, do they know if to call into as well?
Kelly, say that again, the folks who have called in?
No, I was just asking, do the other, I think I saw there was a couple other callers, and I just wondered if they knew to call in as well. It looked like they're on the WebEx. There's two. I saw two others, it says call in user 3 and 5.
Oh, yes.
I don't know who that is.
So, so I think two additional people had joined. I know one is Len, and then there's another person as well, but they you might be on mute. And so so we have slides. We will also send out the slides, the presentation at the end as well, just in case. We know that some people are only able to join by phone and not always through the online system. Okay, so so this learning collaborative is focused on care coordination models for older adults with diabetes and other chronic conditions. And the goal of this learning collaborative is to examine the various models of coordinated care and referral processes for older adults with diabetes and to look for best practices. We have an expected outcome, which is to develop a guideline on improving coordinated care and referral processes specifically for oral health and behavioral services among elderly diabetics. So the United States continues to experience incredible transformation. Over 10,000 baby boomers are turning 65 every day, and this age wave, or silver tsunami, is expected to continue well into the next century. The population aged 65 and older has increased by almost 25% and is projected to more than double to almost 100 million in 2060. By 2040, there will be about 82 million older adults, over twice their number in 2000. People 65 and older represented approximately 14% of the population in 2013, but are expected to grow to be around 22% of the population by 2040. And furthermore, the 85 plus population is projected to triple from 6 million in 2013 to almost 15 million in 2040. So what does this mean for healthcare providers and the healthcare delivery system? And we'll talk about the impact and see the impact as we progress through our discussion. The 2015 White House Conference on Aging identified several themes collected from public input on long-term care services, one of the themes identified was to promote person-centered care that maximizes independence and choice. One of the crucial areas identified under that theme was care coordination, as it has the possibility to achieve high-quality care across all settings through which people receive care. And according to the SCAN Foundation, it is considered to be the cornerstone to improving care while also lowering costs. So this session in particular is on aging, diabetes, and comorbid conditions. And as we begin our learning collaborative on care coordination models for older adults with multiple chronic conditions, specifically diabetes, today's session will explore aging, the diabetic older adult, and comorbid conditions that can impact their diabetic health status as well as their overall health status. So the objectives today are to briefly understand the normative aging process and to understand the interplay between diabetes and a couple of other comorbid conditions among adults 65 and older. So the aging process is a pattern of life changes that occurs as we grow older. It generally involves slowing down of systems and can vary greatly among individuals since it is influenced by genetics, environment, as well as lifestyle factors. We can think of age and the aging process in different dimensions. For example, the dimension of biological age, which is the relative age or condition of a person's organs and body systems, or psychological age, which refers to a person's adaptive capacities, and social age, which refers to a person's habits and roles relative to society's expectations, and then, of course, legal age, which is based on the chronological years. Often as individuals age, we think to the physical changes that occur in one's body. Physical changes in the aging impact all organ sensory aspects. And this slide shows a list of some of the age-related changes in major organs and systems. For example, cardiac function. Even up to age 80, there are no substantial aging-related changes in overall resting cardiac function, but there are notable age-associated changes in specific aspects of cardiac structure and cardiac function, and particularly lifestyle-associated stressors such as poor diet, physical inactivity, and smoking can accelerate these changes. I think one thing that we commonly think about when we think about age-related changes, we think about some common age-associated metabolic changes, and particularly their impact on chronic conditions such as diabetes. As we age, it appears that insulin sensitivity seems to decline, and in particular, skeletal muscle is an important site of age-related insulin resistance. And some factors that contribute to age-associated insulin resistance includes visceral adiposity and associated adipokines and inflammation, oxidative stress, and mitochondrial dysfunction. And so these are all changes that occur with the aging process and are exacerbated again by some of the lifestyle factors that I had briefly mentioned. Additionally, there may be changes in cognition as people age. Memory tends to slow with age like other functions, but decline in the ability to remember things is not a normal part of the aging process. It takes us longer to retrieve the information we are looking for, and the same is true of learning. While we could acquire information relatively quickly and retain it well when we were younger, it takes more effort to process, store, and retrieve information as we age. So as we age, we can expect to take more time to think things through, spend more effort learning, and occasionally have difficulty remembering something, but eventually these tasks are completed. As shown in the earlier slide, as people age, there are detectable changes in the brain, Its weight, the weights of our brain declines by about 10% around age 80. Our blood flow within the brain diminishes, our nerve conduction slows, and we also can experience some nerve cell death. Our cognitive abilities decline gradually with these changes, but for most people, they tend not to affect overall function or activities of daily living. However, for some individuals, cognitive decline can have a more substantial impact on daily living, and cognitive decline has been categorized into both mild and major neurocognitive disorders. And these diagnoses come with subtype categories that include impairments consistent with neurodegenerative diseases such as vascular dementia and dementia of the Alzheimer's type. It's important to understand and recognize the difference between normal aging and neurocognitive disorders. And so the box is a pullout which shows dementia, for example, Alzheimer's disease, which can affect an estimated 1 in 10 persons over the age of 65, and dementia in particular can affect a considerable number of people over the age of 85. It's a stage progression where we may start with forgetfulness and memory loss that then accelerates to a final progression of complete disorientation and loss of control with body functions and independence. As a result of physical changes in aging, again due to genetics, environment, and lifestyle factors, there are several common chronic conditions that plague older adults. We know that chronic health conditions are the most prevalent and disabling illnesses facing older adults. Even more than a decade ago, they accounted for over 3/4 of the U.S. medical care costs. With the rising number of older adults with the same chronic conditions, the medical care expenditures in the future will continue to rise. Chronic conditions have a substantial impact on quality of life. As individuals are living longer with their chronic conditions, care management or care coordination, that is managing symptoms, preserving function, and minimizing future damage to ensure quality of life becomes paramount. One particular common chronic condition in the focus of our learning collaborative is diabetes. Based on data published in 2015, approximately 10 million adults over the age of 65 have been diagnosed with diabetes. That is over 1/5 of the population, and more current estimates put it at 1/4 of the people over the age of 65 have diabetes. Among adults aged 65 years or older in the U.S., the combined prevalence of prediabetes and diabetes, that is both diagnosed and undiagnosed, ranges from 50 to 80%, depending on which measures of hyperglycemia are used. And we know that these proportions are likely to increase dramatically in the next couple of decades with the increase in the number of the older adult population. Furthermore, the cost of diabetes is very high. Approximately $300 billion is spent annually on patients with diabetes, and the majority of these costs is spent on individuals who are older who may have long-standing diabetes and complications, severe complications from the diabetic condition. So we think about the impact of diabetes on older adults. Older adults with diabetes are at greater risk than other older adults for several common geriatric syndromes. For example, cognitive impairment, urinary incontinence, falls, and the sequelae of those falls, as well as pain and polypharmacy, so multiple medications and the impact of taking those multiple medications. These syndromes can impact older adults' ability to also self-manage their diabetes. And so we end up in somewhat of a cyclical pattern. Type 2 diabetes increases the risk for both vascular dementia as well as Alzheimer's disease. So the impact of diabetes on older adults' cognition is important. Older adults with diabetes are at a higher risk of cognitive decline and potentially institutionalization because of that cognitive decline. The presentation of cognitive impairment can range from subtle executive dysfunction to memory loss and debilitating dementia. People with diabetes have higher incidences of all-cause dementia, Alzheimer's disease, as well as vascular dementia than individuals who do not have diabetes. And diabetes and Alzheimer's disease can also have synergistic effects with age on the vasculature of the brain, including the blood flow and delivery of nutrients for sustaining cognition. Deficits in memory and executive function can appear in midlife and become progressively worse as we age, and this creates a cycle of increasing cognitive impairment and poor self-management. Additionally, older adults with diabetes have higher rates of premature death, functional disability, accelerated muscle loss, and other coexisting conditions. And this slide shows the estimated number and percentage of older adults with chronic conditions. And you'll see on the table where the second column is the number of people, the number and percentage of people who do not have any chronic conditions, all the way to the right-hand column where individuals have greater than or equal to 3 chronic conditions. And you can see that at least a quarter of the population over the age of 65 or older have 25% have at least one chronic condition, and almost a third have 3 or more chronic conditions. And it's likely that one of these 3 conditions is diabetes or even pre-diabetes. So also looking at some data with respect to the impact of diabetes on older individuals. Individuals with diagnosed diabetes can be at a higher risk for coronary heart disease. It can also, even people with prediabetes can have an elevated, slightly elevated risk of coronary heart disease as well. And you can see here in this figure major diabetes complications among adults with diabetes. And so we have complications from hyperglycemic death. We have amputation, which I think most people think about in terms of complications from diabetes with resulting neuropathy and then amputation. We also see, particularly in the older adult population, emergency room hypoglycemia. We also see increased numbers for the 65 and the 75-year-olds with respect to stroke and ischemic heart disease, as well as I had mentioned coronary heart disease. This figure shows what the pathway may be between aging and type 2 diabetes and cardiovascular disease, particularly through the pathways with hypertension and impaired cholesterol. And so you can see here that oftentimes we find that older individuals with type 2 diabetes tend to be overweight. And usually in aging you have a decrease in physical activity, which impacts our energy expenditures and the deposition of fat in our body, which may lead to obesity and as well as insulin resistance, and then these, of course, will all trickle down into higher risk of hypertension, type 2 diabetes, and dyslipidemia, which then impact cardiovascular disease. Another area that we've looked at is the relationship between diabetes and periodontal disease. And there's been growing evidence that demonstrates the relationship between systemic diseases and oral health, with the premise that periodontal disease and other systemic diseases have a bidirectional interaction. Previous studies have shown a strong correlation between periodontitis and type 2 diabetes, and evidence of periodontal disease's impact on glycemic control of diabetic patients and the triangular relationship between periodontal disease, diabetes, and obesity has been cited. Because periodontitis can be seen as a possible early sign of diabetes, it does have the implication that the dental office or the dental clinic that treat patients with periodontitis could potentially be a suitable location for screening patients for prediabetes or diabetes. And so thinking about the possibility of screening and coordinated care. In terms of managing comorbid chronic conditions, HHS has information on multiple chronic conditions among Medicare beneficiaries in terms of data and state-level chronic condition reports. And they also had focused on this in the White House Conference on Aging, and that the administration at the time recognized the need for a cultural change in how we address chronic conditions, like diabetes in particular, and the need for a focus on supporting health. And so thinking about understanding the impact of multiple chronic conditions and the care conditions that would be important to consider. So I wanted to leave you with a couple of the recommendations from the Standards of Medical Care in Diabetes. This was published in, I think it was in January, just the beginning of 2018. And this is the section on the Standards of Medical Care in Diabetes for older adults. This is actually the overall recommendations for older adults with diabetes. They said to consider the assessment of medical, psychological, functional, and social geriatric domains in older adults to provide a framework to determine targets and therapeutic approaches for diabetes management. And second, screening for geriatric syndromes may be appropriate in older adults experiencing limitations in their basic and instrumental activities of daily living, as they may affect diabetes self-management and be related to health-related quality of life. And then a couple of more specific recommendations. This one on neurocognitive function, and the recommendation that healthcare providers should screen for early detection of mild cognitive impairment or dementia and depression for adults 65 years of age or older at the annual visit and annually as appropriate. And then lastly, the specific recommendation on hypoglycemia. And you might recall from what I had mentioned earlier with ER visits related to hypoglycemia, that hypoglycemia should be avoided in older adults with diabetes. It should be assessed and managed by adjusting glycemic targets and pharmacologic interventions. And so I wanted to, with our remaining time, bring it back to, I should say, bring up some discussion points and bring it back to the overall goal of this learning collaborative. And our first discussion point is, what type of coordinated care do you employ with your diabetic population? And then specifically, do you do anything different if the individual is over age 65? And so I'll open it up to anyone who is who has something to share or would like to comment on this question and sub-question.
I have. When we see dental in the dental office and when I'm teaching in the dental schools, one of the things, diabetes really is an integrated approach to care. An example, yesterday we were in the clinic with the students. We were looking at a case, what would be called, or looked at as a simple case. And what was brought up was, if you have somebody that's 80 years old that's coming in for a simple extraction, what do you have to deal with, and what are your other types of collaborative members that should be involved in that treatment? And it's really a team approach, because you have to have a patient you have to be aware of. Do they eat before they come in? Sometimes we have to contact family members. We have to be very careful. You described it really well, Christine, when you were looking at how each organ system can decline. So knowing that a kidney and a liver may decrease 1% per year after the age of 40, we have to be very careful looking at the medications. We may have to call the pharmacist, we may have to call the physicians. We have to be also very careful of the foods that they eat before they come in. Dentally, one of the things that seniors will do is they won't eat before they come in because they don't want to come in with dirty teeth. And where their sugar control is so important, they need to. But my greatest fear is when they leave the appointment and they go home, knowing that their thirst mechanisms are less as we get older. They dehydrate very, very quickly, and they may not eat, so they may not manage their diabetes when they leave. So follow-up phone calls either from the office or from their physicians. It's really a great example of complete integrated care. And you also had made the point, Christine, that we worry about falls. We really worry about falls on two: when they come into the office, if they haven't eaten, if they're unbalanced, and also at the end, if they're home and they're home alone, we have to be sure that family and nurses or CNAs or home caregivers are part of the treatment team. So diabetes, when somebody comes in, we have to be careful pre, and the visit doesn't end until we talk to them at least the next day to see how they're feeling and if they have followed the instructions of care. So it's a great example, and it's one of those that I think that the dentists and dental students and physicians and nurses all have to be aware of.
Great, thank you, Len. Those were really great examples of the impact of not only diabetes but aging and how even taking a visit to the dental office, if the provider's not thinking about those things, how they can affect what they're doing, as well as what happens to the patient when they leave. And so thank you so much for sharing that. Any other comments about this question, or responses, I should say?
Christine, I have a question for you. When you were looking at diabetes, and how receptive are the senior patients in following like an integrative model of care and a collaboration? Do they understand what that is? Because I know that we spend a lot of time talking to colleagues about it, and when I deal with seniors, they all want to make us happy, and they'll feel that they'll tell us that they understand, but I'm not really sure if they do. What is your feeling on that? Do they understand when we say coordinated collaborative care?
I think that some do, and they may understand it on a very high level, but I think that if you were to ask them specifically what that means, I think that that some of them don't completely understand what that means.
This is Kelly Rice.
Hi, Kelly.
We actually, one of our partner agencies actually just did some focus groups with older adults, and it was more around like the insurance part of coordinated care and things, but one of the things that came back really clear was folks really struggling with understanding what coordinated care was, especially when you throw in the managed care companies as well that have their care coordinators as well as their primary care staff. And I think there's a lot of confusion and a lot of not really understanding how to navigate the system and who's coordinating what.
Yeah, that's excellent. If you have more information about those, about the focus groups, would love to see what they had found. Do you know, are they going to publish it or put out a white paper or a brief or something about their findings?
I'm not sure. I was just at the meeting. It was probably about 2 weeks ago. I can reach out to them and see. And even if they're not going to share on a more public level, I can see if I can get at least like the slides from their presentation and things so that I could share that with everybody.
Oh, great. That would be fantastic.
That's great.
And I think that particularly within insurance, because as I had discussed earlier, specifically for diabetes care, it's a very expensive chronic condition with over $300 billion in costs. And certainly health insurance companies are trying to reduce costs as much as possible. And so looking at coordinated care, integrated care as a way to reduce costs, but hopefully also increase patients' health. But if the patient doesn't quite understand what coordinated care is supposed to do or what it actually means, and therefore might not either follow through with referrals that are made or understand what their role is in the coordinated care and how it relates, as well as what it means for their insurance costs and insurance reimbursement, then it makes it a little bit more difficult to get them to buy into the frame of coordinated care.
You know, and one of the other things when we're looking at, you know, this collaboration to patients now, one of the greatest struggles as a healthcare provider is to have that acceptance with other colleagues. So to coordinate the care, I think one of the reasons that patients are a little bit confused on which direction and what this team approach mean, many times still in the healthcare profession, we are still in our silos, and that's one of the reasons I think a program like this, where we have this collaboration, we can talk, through different disciplines, it's very valuable. So that I'm clear on what physical therapy and OT and CNAs and other team members do, so that I feel comfortable calling and they feel comfortable accepting my phone calls. And it's still a struggle, but I think this type of a program really can make a difference, Christine.
Well, that is a good segue into just the next question, and thinking about what do you need as providers to manage not only your patient's diabetic condition, but also to optimize coordinated care and or referrals to specifically behavioral or cognitive and cognitive services and oral health services. So again, kind of reflecting back to what Len had just mentioned with respect to even coordinated care, it also requires us to understand what the different disciplines are do with respect to caring for the patient, and that starting at that level of even just understanding gives us a better idea of where those people can come into the coordinated care process and how to even reach out to them, because you know exactly what their role in the care of the patient would be. So, so again, I just want to put out to this question for discussion: what do you need to manage your patient's diabetic condition and to optimize coordinated care and or referrals to cognitive, behavioral, and oral health services?
I know one thing that I'm looking forward to with our agency is starting June 1st, we are going to have diabetes-specific case management. And so I feel like that's going to be really huge. At least in Chicago, both behavioral services and oral health services are really challenging to access, especially for our low-income folks. And so it's not something where you know, the nurse or the provider or whoever can just do a quick referral and it's sent over and it's done. It's something that requires a lot of time, a lot of follow-up and coordination. And so for us, I think having at least 1 to 2 people that are really dedicated to that's what they're doing is going to be huge. And then I also feel like with that amount of time that they're spending with patients, we're hoping that we're going to get more buy-in to some of the health and behavior changes as well.
Oh, that's fantastic. So, so you'll have, I think did you say June 1st, Kelly?
Yes.
So you'll have a dedicated diabetes case manager?
Right.
And do you, is it just one individual, or were you able to secure a few slots?
Well, we currently do not have any funding. We have applied for funding, but we're going to just kind of go ahead right now. So we'll have 1 person in June, and then we're hoping to add more in the fall.
Oh, fantastic.
Yeah, it just depends on kind of the funding piece of it.
Oh, okay. Okay, great. So I think you had mentioned with respect to the challenge in referring for behavioral health and oral health services that particularly for the patient population, it can be a struggle because of being on, I'm assuming being on either Medicaid or Medicare in general.
Yeah, the biggest issue for us is our Medicaid system. They're so behind in paying, especially with the oral health services. That's where the real impact comes in. They're very particular with what they even cover with oral health. Like, they do not cover exams, they don't cover cleanings. They only cover, you know, kind of the absolutely dire necessary services. So there's, you know, that piece of it, so our folks are not getting that regular cleaning and care. But even trying to find providers that are doing the other care is really challenging as well, because the pay is so low and so it comes so late that they've either reduced the number of Medicaid patients that they're seeing or the amount of days that they're seeing patients, and so access has been really limited.
And did you say that you're in Illinois?
Yes, I'm in Chicago.
Okay, okay. Well, Len, that's really interesting, because aren't you going to be at the ADA, or were you just at the ADA, which is where?
We were just at the ADA looking at how do you place oral health care in Medicare B, and it's a juggle, because we're dentists. Medicare really doesn't have services, and it may have services in, say, 17 states. You make Medicare, and so you have most of the population without any services. Even the services that they technically cover, if there's an infection, it's very difficult to get coverage for it. So, but the dilemma is how can you afford the services and at the same time have the dental community accept those fees? And one of the greatest dilemmas right now is that a lot of the students that are coming out of school, they have such debt. And the amount of that debt can be anywhere from 75 to 90 some odd % of their overhead. So for every dollar that comes in, if say it's 90%, 90 cents on every dollar goes towards your overhead. One of the dilemmas they're having with the Medicare fees is if you have a patient that comes in and is paying 60% on a dollar, it means the dentist can lose for every patient that comes in. So it's more than just the Medicare portion, but how do you look at this whole beast and try to control it? So, but one of the things that I find now are people are looking at it and are supporting some of those fees, and it's an interesting debate. I love where we are because we are chatting. So we certainly look at that problem, Kelly, and hope, because most of my career has been dealing with what do we do with these seniors because they just do not have care.
Any other comments about managing patients' diabetic condition and coordinating care with some of these other services, particularly behavioral health and oral health services?
I have a question for Kelly. I was going to just ask Kelly, how do they train the caseworkers on terms of the disciplines on where they would shuffle the patients?
So right now, what we are going to be doing, because we provide medical case management for HIV, and the case manager that we've identified that's going to start on June 1st is actually one of our current Ryan White HIV medical case managers. And so she already has a wealth of experience navigating all the different systems. And she also happens personally to be diabetic as well, and so she has a pretty thorough understanding of, and she's type 1, she's had it for a really long time, and so has a really good understanding of the condition, the impact, the treatments, all those things. And so it's more about just trying to, it'll just be more about how do we navigate. There's a lot of funding out there for HIV supportive services and not necessarily so much for other conditions, so just trying to navigate how we do that I think is going to be more of a challenge. But I think with her coming from the HIV medical case management model, we do a lot on treatment adherence and all those things, so I think it's going to translate really well to diabetes.
It'd be great to train other people, other individuals, It's great. Thank you.
The other thing that I was just going to throw out that I think is going to be a challenge for our systems in general, as well as in looking at the rates of diabetes, and that we're going to see that grow, as well as making sure that all of our medical staff and behavioral staff and oral health staff are really competent in diabetes care, at least at a certain foundational level, because most people are going to be interacting with people with diabetes, and so I think it's really important that they have at least that strong foundation to be able to fall back on.
Yes, that's a really excellent observation, because as you said, and what Len had mentioned earlier, if you have diabetes, it can impact these other systems, and it's really important just across the health provider spectrum to understand what impacts it can have on these different systems. So, you know, even in terms of medication and the ability, you know, not only are they diabetic, but they're older, and the ability to clear medication or polypharmacy in an older individual with diabetes might be a very different thing compared to a younger individual, and understanding all those impacts. So I think that's really important given the prevalence and the growing prevalence and incidence of diabetes in the population in general.
Well, you know, there are guidelines.
Yeah.
Yeah.
And that's, you know, one of the things that we've been looking at as because one of our goals under the HRSA funding for our center is to reduce the percent of people with A1Cs over 9. And one thing that I did want to point out with respect to the diabetes standards of care is that for older individuals that in terms of the treatment goals, depending on whether or not there's comorbid conditions, if they have cardiovascular issues, if they have hypertension, that the overall guidelines don't necessarily fit. And so it's another thing that providers may need to better understand in terms of the impacts of some of these other chronic comorbid conditions, and by having a set goal may not be the best for the patient, particularly for the older adult diabetic patient. Great. So I see that it is 1 minute to noon, and we want to be respectful of everyone's time. I just wanted to thank you again for participating in this first session of our Learning Collaborative. Our next session will be care management in older adults with diabetes, and it will be May 24th. And so we will send out a reminder about that. And again, wanted to thank you for participating in today's call. If you have any follow-up questions, please feel free to reach out to us, and we can respond to those questions. Otherwise, we will hear and see you online on May 24th.
Can we get a copy of the slides as well?
Sure. Yes, we actually will send out a copy of the slides and a copy of the recording as well.
Cool, thank you.
Great, thank you everybody. Have a good rest of your day.
Yeah.
Bye-bye.
Bye-bye.
Bye-bye.